Good morning, everyone. Good morning. Thank you all for coming. My name is Mike Lucchese, for those who don't know me. I'm the chairman of emergency medicine here. I'm also the chief medical officer at University Hospital. And in this interim period between presidents, I'm the officer in charge of the campus. So I want to thank everybody for coming here. Tell you a little something. The Brooklyn Coalition for Emergency Preparedness consists of 11 Brooklyn hospitals and 3 long-term care facilities who've been working together on emergency preparedness for about the last 4 years. It's funded by the New York City Department of Health and Mental Hygiene. The coalition is taking the leadership role in conducting this comprehensive active shooter symposium and exercise. It's the first time in the borough of Brooklyn that anything like this has taken place. This 2-day event is designed to help healthcare providers and staff be better prepared to react to an active shooter in the hospital and in other healthcare settings. We're very happy that our hospital at the SUNY Downstate, University Hospital of Brooklyn, is the lead hospital in the Brooklyn Coalition and can facilitate this event. Today you're going to hear from active shooter and emergency preparedness experts from around the country on best practices in response to an active shooter. This should be a very informative and thought-provoking 2 days. So this is extremely important. And again, I want to thank you all for coming, and especially our guests from down south. It's really an honor to have you people here. So why don't we get started?
Good morning. I'm Dr. Stephen Burgher, an emergency physician from Dallas. First of all, let me just say on behalf of Global 7 that we're all very grateful for this opportunity to work with you all, to be here. And I'll just say up front, we don't have all the answers. We're here to help stimulate the thought process as we face growing threats to our communities. What works in Texas may not work in New York. We readily acknowledge that. So we just want to share lessons learned and hopefully share principles and ideas that will stimulate thought that can work in your program or your hospitals. But again, thank you so much for the opportunity to work with SUNY Downstate. So a little background, I'm an emergency physician at Baylor University Medical Center, downtown Dallas. It's a level 1 trauma center. We are on the east side of downtown to the west there. We're one of 2 level 1 trauma centers in Dallas, the other one being UT Southwestern Parkland Hospital. The 2 major level 1 trauma centers there. By way of a little more background, I am in the Navy Reserves. I serve with the Marine Corps currently on my reserve side job. I've had a couple of deployments in the past 3 years. One of them was to Afghanistan from 2013 to 14, which really stimulated for me a lot of these principles that we weren't necessarily using back home in our trauma center, and now I'm grateful to see that a lot of these principles are translating into what we do in our practice in our trauma center, and seeing that in trauma centers around the nation. Had another recent deployment, got back in May from with the Marines to the Middle East, where we were contributing to the fight against ISIS. So have been able to see some of these principles at work in combat. Not everything that works in the military necessarily applies to the civilian sector, but a lot of the principles do, and that's what we hope to share. Just a little disclaimer, the views here are that of my own and not that of the Department of the Navy or the Department of Defense. Just that little disclaimer out there. Also, I've tried to get most of the graphic content out, but there may be a few slides that have a little graphic content, so I apologize for that in advance. Prepare yourself. And the other thing I would just make mention of, there are a couple of pictures that have commercial products. I use those more for historical purpose or just to give an example. I'm not here to promote any one commercial product over another. With that, we'll move forward. So the objective here primarily is to talk about number 1, talk about the characteristics of active shooter events. I also want to discuss the Hartford Consensus that has come up with the Stop the Bleed program campaign that I want to at least make mention of, again, because there's principles in it that apply to our security. The next thing I wanted to talk about is the medical management of severe hemorrhage as the main focus of addressing an active shooter consequence. So just by definition, just wanted to start with, well, what is an active shooter? So Homeland Security has this definition that an individual actively engaged in killing or attempting to kill people in a confined and populated area. In most cases, active shooters use firearms, and there is no pattern or method to their selection of victims. That's the basic definition of active shooter that we use. So this is, as far as characteristics, this is a study that the FBI, or at least data that the FBI put out in 2014, looking at 160 active shooter events from 2000 to 2013, and where they occur. So note that about 45% of incidents occur in places of commerce, business. Most of those open to public access and foot traffic. Another 25% have historically occurred in education facilities. We think of Sandy Hook, we think of the Virginia Tech shooting and others, where they've occurred on campuses. Note that about another 10% in government facilities, about almost 4% in places of worship. I also point out that about 2.5% historically have been in healthcare facilities. So we in healthcare facilities are more used to the traditional receiving casualties already packaged, brought to us from an external event. We're not the event. Part of our focus today is to change that thought or paradigm, at least introduce that change, where we may actually be the ground zero. We might just be where an incident occurs internal to the hospital, and what is our response there? Stimulate that kind of thought. There is more increasing threat traffic and chatter going on that has made us more concerned that healthcare facilities may have an uptick in being the ground zero. So that leads us to what we're doing. Some other characteristics when we look at the most deadly mass shootings in the U.S., we see that the incident in Orlando, the recent incident last year, has topped the chart now with the number of casualties, both those who dead and injured but survived. Some other just characteristics. Note that about 40% of active shooter events end by the perpetrator committing suicide. 28% end by law enforcement neutralizing the threat. Another 13% by unarmed citizens, another 3% by armed citizens neutralizing the threat. About 50% of active shooter events have ended before law enforcement gets there. While law enforcement and EMS usually respond very quickly, there can be delays that occur, and that means delays in getting to the victims and treating the casualties. As far as law enforcement, they're very, median response time getting to the threat, 3 minutes. Usually, the majority of incidents, 75%, close to 75%, are ended by 9 minutes. So that's good. But that means about 25% can go a lot longer, and that has to do with, is the perpetrator barricaded, or is there more than one perpetrator, or the potential for more than one? Is it a mobile target? So there are things that can delay it, and those delays are, it used to be the golden hour getting to, we consider it in trauma. Now it's really like the golden 5 minutes, because when there's catastrophic bleeding, you can bleed to death within 5 minutes, and so 9 minutes may be too long. So that's part of the focus of what we're going to talk about, is what can be done to mitigate that those catastrophic events. I also want to just, I'm going to point out the two recent events in this past year, mainly to bring up a couple of lessons learned. One is the Orlando event that occurred on June 12th of 2016. As mentioned on the previous slide, this is now tops the chart in terms of most deadly, most catastrophic event in U.S. history. The casualties arrived by vehicles of opportunity to the nearest hospital, which was Orlando Regional. There was no notification. Vehicles just showed up. The initial wave of patients just showed up. There were 35 gunshot victims that arrived in the first 30 minutes, which any ED, I don't care if you're a trauma center or not, if you're the busiest trauma center, 35 gunshot victims in 30 minutes will overwhelm any facility. The police perimeter, which needed to occur, made it difficult for hospital staff subsequently to respond and get into the facility. Something to think about in our hospital planning, because it is we need to plan for a inner perimeter and an outer perimeter. That is for the security of our facility. We'll talk a little bit more about that going forward. But the other thing, though, we need to also, in that context, plan for how is our staff who's not on duty, how are they going to get in and help out and show up for the fight. The other incident I want to make mention of occurred in Dallas, and our facility and Parkland, the two level 1 trauma centers, about half of the law enforcement officers went to, about 50-50. Half went to Parkland, half went to us. I happened to be on duty that night, and literally at 2100, there were shots fired downtown. No one in the ED knew about it. At 2107, our first casualties arrived, and there were 7 casualties that arrived by vehicles of opportunity. There were 4 police squad cars that came high rate of speed, 1 car riddled with bullets on rims, sparks flying. They came running in with the casualties. 7 casualties at 2107. Again, we're a level 1 trauma center. Even 7 casualties all at once can overwhelm a trauma center. So one of the things, because these vehicles were at the crime scene, they were shot up, they were part of the crime scene. So that's something to think about. We'll talk a bit more about security, but I want to just bring up some of the lessons learned was, okay, now our ambulance bay is a crime scene. The initial plan, not from the emergency department standpoint, but the initial plan from law enforcement was, we need to leave them where they are. This is a crime scene. And we were like, okay, well, patient care needs to come first. So we needed to move and adjust the crime scene a little bit and clear the area for what we were anticipating as another wave of patients. So because of the data I showed you that all the various active shooter events in the past decade and a half, and because of incidents like Orlando and like Dallas and like the Boston bombing at the Boston Marathon, things like that, it led to what's called the Hartford Consensus, which is strategies to improve, to enhance survival. And we'll talk a little bit about what's come out of that campaign. But the basic goal of the Hartford Consensus was to increase survival from these events. And it was to take a multidisciplinary approach. So representatives from the medical community, the military, law enforcement, fire rescue, and EMS got together, came up with what are the issues that need to be focused on. And the biggest thing is the recognition that hemorrhage is the leading cause of preventable death in these events. So thus the Stop the Bleed campaign, and that no one should die from uncontrolled bleeding. And that is basically the mantra of the Hartford Consensus. So dealing with hemorrhage being the leading cause of preventable death, I want to show you this data, and this was published in 2012, and this is data that came out of our wars in Iraq and Afghanistan. And from that, we're able to look at the trauma database, and when we look at casualties that occurred, number one, 75% of casualties are not preventable. So in the battlefield, 75% are not preventable, but that means 25% are preventable. And of those preventable or potentially survivable incidents, hemorrhage by far and away, 90%, was the cause of death. And we look at extremity hemorrhage versus junctional hemorrhage, which means like in the groin or the axilla, or truncal, meaning to the main body. Airway was second to that, about 8% airway obstruction, and then tension pneumothorax, about 1%. So those are 3 preventable causes of death, meaning we could have done something about it if we had the right training and tools. And that led to a change or a shift in the focus over this past decade and a half in the military in terms of our training focus and principles. And it's based on treating the preventable causes of death. Number one, hemorrhage control, followed by tension pneumothorax and airway, and rapid extrication or rapid medevac to a definitive facility where they can get to care. And what was really pushed is that what takes place before they get to a treatment facility is what's going to save lives. That golden 5 minutes occurs in the field. It doesn't occur in the hospital. That golden 5 minutes is from point of injury, taking care of the bleeding or the airway or the tension pneumothorax before they get to us. And so that was what makes the big difference. And so it led to an approach that TCCC, or Tactical Combat Casualty Care, is focused on. Let me go back. Is the acronym MARCH, and this is basically sets the priority of care, and we use in the military for our hospital corpsmen and medics. It easily translates to what takes place in the civilian sector in this approach. To number one, deal with massive hemorrhage, followed by airway, respirations or breathing, circulation, and then H for head injury and hypothermia. So those are the main focus or the priority of care in that order. March. And again, because both in combat and civilian active shooter events or intentional mass casualty producing events, uncontrolled hemorrhage is the number one leading cause of preventable death. I want to talk about that just a bit. So I would say the number one development or area of progress that we've made in this past decade or more through the wars in Iraq and Afghanistan is the use of tourniquets. That has saved more lives than probably any other single intervention over this past decade and a half. When I did my training, don't want to date myself, but back in the 90s, tourniquets were not to be used. In fact, they were to be used as a last resort, if at all, and you better be ready to stand before a judge and answer why you used a tourniquet, because there was such fear of losing the limb, over and above thinking about the consequence of losing the life. So tourniquets were not promoted in the military. The first casualty in Afghanistan, the first casualty in the wars in Iraq and Afghanistan occurred in Afghanistan, and it was an individual who had a penetrating injury to a limb and he exsanguinated. And definitely was preventable. As a consequence of our military personnel seeing things like that happen, they started getting tourniquets off the shelf and started using them. And anecdotally, hey, this was saving lives, making a difference. So the Army caught on and said, well, we better study this. They looked at 9 different tourniquet products that were out there at the time. And in 2004, came up with the combat application tourniquet. And again, I'm not promoting one particular product. This is one of the tourniquets. Historically, this was the one that the Army approved and became standard issue in 2005, so that every soldier and Marine and sailor would carry 2 tourniquets on their person at least for hemorrhage control. And that became standard issue as a result of the study that came out in 2005. Before 2005, it was not standard issue. And to validate the benefit, there was a study published in 2009, and there's other studies, but this one is pretty potent in that it points out that early tourniquet use before there is shock is associated with significant improvement, so that if a tourniquet's applied to control hemorrhage and shock is not present, 90% survival rate. If the tourniquet's applied kind of as a last resort, now the patient's getting shocky, so shock is now present, they're diaphoretic, they don't have much of a pulse. Now we apply it, 10% survival rate. Well, 0% if you don't use it at all. So tourniquets make a difference in this, as validated by this at least one study. Tourniquets are pretty simple to use, and that the reason that the CAT tourniquet was the one chosen in 2005 is because of its simplicity in use, easy to use, and effectiveness. So it could stand the also being in the that austere environment and applying it in the field, and the pressure required to dial up to stop things like lower extremity hemorrhage. Simple kind of 4 parts to it. You basically have the band or strap that's Velcroed, and then you wind it with the windlass rod that then connects to the clip, and you time it. Simple. Put it on there. Oftentimes, for lower extremity injuries, oftentimes it requires 2 tourniquets. Upper extremity, typically 1 tourniquet will do, but usually lower extremity massive hemorrhage needs at least 2 tourniquets. So that big fear back before OIF and OE. There is about a 1.7% transient nerve palsy, as far as that's the biggest complication. As far as having to require fasciotomies or long-term or even getting amputated, it wasn't because of the tourniquet that these consequences occurred. So saving the life definitely proved to be much more beneficial than the risk to the limb. The other advance over the past decade or more has been the use of hemostatic agents. So again, this is just one example, quick clot, but there's other hemostatic agents. And hemostatic agents are basically compounds that help accelerate clot formation. There's a variety of them out there, and there's newer ones even now being developed that are bigger and better, faster. But as an example, with the combat gauze, which became standard issue with our Marines and sailors in the field as part of their kit, this gauze has that hemostatic agent in it, and helps accelerate the clot. So that if you use just regular gauze without the hemostatic agent and applied it to a wound, typically you need to hold pressure for 10 minutes. Versus with the hemostatic agent, you can reduce that to 3 minutes and expect to be, if it's going to be effective, 3 minutes is long enough. And this is just an example of a wound being packed. This is particularly helpful in wounds that are proximal to where a tourniquet would be beneficial. So more junctional or truncal injuries, where you pack it with a hemostatic gauze. So again, just the focus on minimizing hemorrhage, stop the bleed, thus the Stop the Bleed campaign. This concept of using March as our principle, as the prioritization of our treatment principles, stopping massive hemorrhage being the first principle. Using either pressure dressings, tourniquets, and the hemostatic agents, or some combination of the above. The other thing is just minimizing transport times and on-scene procedures. That's, the whole idea of starting an IV in the field is, get them to a treatment facility, do these things to stop the bleeding, do simple things to protect and open the airway, and if you need to, needle a chest, but get them to a treatment facility. Don't delay messing around trying to get an IV and that kind of thing. So the only other thing I want to mention, this is really more for another brief to present, but in terms of another aspect that we've learned over this past decade or more has been the approach of damage control resuscitation, and damage control surgery. And that has now become really the principle both in our trauma centers as well as in our trauma in the operating room. So we already talked about minimizing hemorrhage, covered that. But the other thing I just make mention of is hypotensive resuscitation and hemostatic resuscitation. And just to briefly mention, hypotensive resuscitation, what we've learned is that, hey, we don't want to jack these people up with a bunch of fluids and bring their pressure up. Keeping them permissively hypotensive is okay as long as they can maintain a pulse, so you can feel a radial pulse, and as long as they're mentating. That's good enough, because if you get the pressure up much higher, you might blow a clot. So the other thing is using things like IV fluids and crystalloids can be deleterious. They can dilute clotting agents and cause problems with acidosis and so forth. So using IV fluids and crystalloids in trauma in the setting of massive hemorrhage is become really something we don't do anymore. If we're going to have to give fluids, then it brings us to hemostatic resuscitation, and that means giving blood products for fluid resuscitation. So if we need to give fluid, we need to give blood, and typically either fresh whole blood or what equates to fresh whole blood in a balanced ratio of packed red blood cells, fresh frozen plasma, and platelets. We augment that with TXA, which has been shown to be beneficial in certain massive hemorrhage scenarios. So TXA, if it's given within 3 hours from point of injury or time of injury. And what TXA does is help prevent the clot breakdown that naturally occurs in our body and sometimes hyper-accelerates in the setting of massive trauma. So I just make mention of that, and we'll move forward from there. So back to the Hartford Consensus, the focus being on hemorrhage control and stop the bleed campaign. And really what they came out of that is, hey, it's not just the trauma centers, it's every medical facility. It's not just the medical facilities, it's law enforcement, it's fire and EMS, it's all first responders, and it's oftentimes the first responder is not law enforcement or EMS. It's going to be the bystander, the general public. So trying to get this campaign out of education, much like we've done with AEDs and early defibrillation for cardiac arrest. So this approach we're trying to do and getting the public aware of, hey, if you can go there and stop the bleeding, you will likely, a good chance, save a life. In the military, we designed, so I talked about this focus on the, preventing the potentially survivable, in terms of preventing, stopping preventable death. We developed these individual first aid kits, and this was carried by is carried by every military personnel out in the field in a combat scenario. Basically, it has tourniquet, combat gauze, simple nasal airway for air obstruction, some gloves, a needle for needle decompression, and some additional bandage wrapping. So that would be on every person. What that is translated to in the civilian sector is law enforcement developing similar IFAK kits. So I know that that's being rolled out here in New York, where law enforcement is being distributed these individual first aid kits that basically has these the same type of contents. And, you know, the use of these individual first aid kits by law enforcement's made the news. This is an article that, an incident that occurred in Arizona where the law enforcement officer had a kit, was able to address the issues with his or her kit, and made a difference in that person's life. Additionally, and sorry for the blur on this, but this whole idea of getting the public aware. So now there's, through the Hartford Consensus, they developed these public access for hemorrhage control kits that are being distributed in places like malls and mass gathering stadiums and so forth. This is one example that the Hartford, that Stop the Bleed campaign has come up with. Here's another one, and this is a product that is I believe being distributed here in New York, and in a lot of the access points, likely to be set up right next to where you would find an AED, and it will have things like tourniquets, combat gauze, those kind of things. So in summary, going back to why we're here and to talk about active shooter events, you know, in any active shooter event, which will be addressed here shortly, the first priority is threat suppression. You can't do anything when you're under fire, so you've got to get the threat suppressed. But the next priority from taking care of the casualties that do occur or have occurred is hemorrhage control, rapid extrication to a place of safety, casualty collection point. Take care of those, again, the bleeding, airway, perhaps pneumothorax, and then get them to definitive care rapidly. And that's the threat priorities and mantra. The other thing I just want to make mention of is going back to the whole issue of security, which I made mention of through circumstances that we faced at Baylor and Dallas, and also with Orlando, where those events occurred. So number one, with any of these events, when there's an active shooter or there's been an explosion, first thing that we need to assume until proven otherwise that these are terrorist events. In that context, we need to be aware of and have situational awareness that there could be a secondary device. Secondary devices can occur at the scene, intended to harm first responders. They could be set up where there would be likely a casualty collection point. They could also be targeted for our emergency departments and hospitals. And we need to have that cognizance. We also need to have that cognizance as we receive casualties to make sure that they have been cleared of any weapons. Certainly perpetrators can mimic and look like victims and try to get in that way. And I know overseas that has occurred and does occur where perps come into EDs and have blown up EDs. I know that happened in Afghanistan while I was there, and it's like, you know, good chance it could, tactic could be employed here in the United States. So we need to be cognizant of that and of our casualties, that we don't just jump in there to care for them until we know that they've been cleared of weapons and so forth. And then the whole issue of to consider, hey, access to our ED, controlling access to our ED, allowing our people to get in, but controlling it, because there's so many access points to our hospitals and EDs. We need to think about how we're going to get a hold of that so that we don't become a scene ourselves. And then the last thing I just mentioned, any of these casualties we take care of, we're evidence, clothing and so forth. We need to be cognizant of evidence collection, but our first priority is to treat the patient. And just a little, if you're interested in more information from the Hartford Consensus. And with that, that's basically what I have for you this morning. Just some food for thought. And if y'all have any questions, feel free. Sir.
That last slide you have.
Yes. Thank you.
That last slide, the first sentence said.
This one?
I'm sorry, the one before.
This one?
The sentence. This is an overall conclusion.
Is this a conclusion that they're a terrorist event? No, I'm just saying that we need to be, we need to presume it is until proven otherwise.
That the experience is proving that out.
That where there is an active shooter and where there's a intentional mass casualty event? Yes, sir. Yes, sir.
General motive for attacking a hospital or a healthcare facility?
So what would the general motive to attack a healthcare facility? Target of opportunity. Generally speaking, hospital security is pretty low, easy access, a lot of people. If from the idea of invoking terrorism and fear, you hit a care point and you've just introduced a lot of fear in the community. And it's an easy access and you can generate a lot of casualties. And it goes with, I mean, the whole idea of a secondary device. It's just kind of an extension of that whole thought process of a secondary device to get first responders, hospitals and so forth. The threat chatter tends to point toward at least the intent to target hospitals more. I'm not saying it's going to happen. It's just there's chatter out there that would make us concerned. Sir. So you're talking about in the military, they have a pararescue that accompanies the soldier? Is that okay? And is there something on the civilian side equivalent? So, yes, sir, that is being developed, and it depends, it's kind of location dependent. I would say in the larger cities, the whole idea of tactical EMS, using EMS providers, not as the initial law enforcement entry, but as the going in with the secondary and tertiary clearing, going in, first responder or EMS personnel going in, tactically protected to render first aid and hemorrhage control. That is being developed and has been developed in some cities, is being developed. I know in Dallas that's been a priority and a focus. Sir. Any other questions? All right, thank you all very much.